Dear scientific committee, dear colleagues, my PhD thesis is Developmental Defects of Enamel, Etiological Aspects and Clinical Management. My name is Mlinkó, working at the Department of Pediatric Dentistry and Orthodontics. As a PhD student, my ambition is to improve life quality of children with developmental defects of enamel with better clinical assessment. And my mission is to discover causes of these defects and finding new intervention protocols that improving pediatric dentistry. To achieve this mission, these two projects about the developmental defects through risk factors and certain metabolic disorders are my specific goals, and I will explain them ahead. My first topic is investigating different types of antibiotics at early childhood as risk factors in molar incisor hypomineralization. The abbreviation is MIH. This disease affecting the first permanent molars and incisors, and this is the most frequent enamel disturbance with the global prevalence of 13.5%. The etiology is still unclear, but we know that the amelogenesis of the affected teeth are at the same chronological time. Many putative risk factors are listed in the literature, and also we know the harmful effect of tetracycline, but less knowledge are known about the other type of antibiotics. So our aim is to evaluate the strengths between early childhood antibiotic intake and MIH. In our question framework, the population are children, the exposure are the different antibiotics, and the outcome is the MIH disease. And our hypothesis is that early childhood antibiotics increase the risk of this dental disease. In our clinical implication regarding to the severe hypersensitivity and the difficult clinical management is to recognize opportunities for prevention. In our systematic search, we used 3 databases and 2 different domains. In the flowchart of selection, we ended with 36 articles, and later we could add 3 more studies, where in the meta-analysis we could add 26. In our analysis, the outcome parameter is the MIH with the measurement of odds ratio with 95% confidence intervals. In our finished analysis are about the risk assessment of the general and prenatally taken antibiotics, and 4 different types of antibiotics are included also. The first figure, you can see the general antibiotic intake, where the normal odds for MIH is 22%. Our population are children, where in the evens part you can see the patients who have MIH. The first 2 columns are the patients who have taken antibiotics, so these are the exposed population, ended with 7,800 patients, and then the second 2 columns you can see the unexposed population, which ended with 9,130 patients who have taken no antibiotics at the early ages. We use the subgroup analysis regarding to the study types. We have case control, cross-sectional, and retrospective observational studies with the heterogeneity level of 77% at the end. This heterogeneity can be due to the risk factor because the dosage and the exposure time of the antibiotics are not known, and the disease also for what they used them. On the right side of the plot, you can see the studies where the MIH was more common with antibiotics, and you can see that the odds ratio is 1.40, which means that the intake of antibiotic at early childhood increased 40% higher the odds of this disease. Which give us this clinical implication that nowadays the prescription of antibiotics are much higher, and we should reduce this and indicate just when it's clear. Here you can see our funnel plot, which is symmetric. In the other 5 figures, you can see the other type of antibiotics where the parameters are the same, and you can see also the same tendency as in the general antibiotic result. None of them are reaching the mathematical significant level as in the general antibiotic group because of the lower number of studies. The strengths of our study is the clear clinical implication, and we have a high population number, and we could reach the significant association on antibiotic usage with MIH. The limitations are the study design, because these cannot establish a strong cause-effect relationship for etiological factors. The number of the studies, which included the different types of the studies, are lower, and the prognostic factor is not well detailed. So in the methods, the questionnaire was mainly used, and there were rare studies which used medical records. Our conclusion is that early childhood antibiotic intake increased the odds of MIH 40% higher, and for the prescription of antibiotics we need a greater public awareness, and because of its multifactorial etiology, now we know that this prognostic factor, so the antibiotic usage, is predominant. The implication for practice is that we should use the antibiotics just when it's absolutely indicated. We need established preventive protocols and accurate medical documentations. In the implication for research part, we need more prospective and longitudinal studies with large sample sizes, and also individual studies with the different type of antibiotics. Also, to avoid memory bias, we need established reference data bank for etiological factors. In our first project, you can see that we have two ongoing parts. And now I would like to introduce my second project, which is investigating the association between phosphocalcic metabolism disorders and developmental defects of enamel. The developmental defects can be qualitative or quantitative enamel disturbances with wide range of clinical appearance. The prevalence, both in the primary and the permanent dentition, is around 30%. And we already know that in the amelogenesis, mineralization phase, the calcium and phosphates are needed for the hydroxyapatite crystal growth. And if there is any changes in the systematic calcium level, it can influence the dental development. So it can have a directly impact in the formation of the enamel. This leads us that there are different pathology of organs which are responsible for calcium storage and the hormonal regulation, like the digestive tracts, bone, kidney, and parathyroid. And so there are diseases which influence the calcium level. For example, the vitamin D deficiency, the chronic kidney disease, or cystic fibrosis with different prevalence level. So our aim is to evaluate the impact of these phosphocalcic metabolism disorders on the appearance of the developmental defects of the enamel. Our clinical question is, are these metabolism disorders increasing the odds of developmental defects of the enamel? The question framework would be the PO with the population of children. The exposure would be the different phosphocalcic metabolisms, and the outcome would be the enamel defects. And our hypothesis is that these disorders increasing the risk of the DDA. And our clinical implication is that these enamel defects can be a warning sign of general pathologies, and also the modifying some behaviors could limit the risk of developing the dental developmental problems. In our preliminary search, we had 3 databases and 3 different domains. Together we had around 1,500 results, and now we are on the Prospero registration. And I would like to make a summary of my 2 projects. In the first project, I would like to submit in June, and the second in September. And I would like to finish my presentation with this quote: "The aim of science is not to open the door of infinite wisdom, but to set some limit on infinite error." So thank you for your attention.
Thank you for your presentation. My question is, what does it mean, early childhood, in your study, in your first project?
Thank you. This is the first 4 years of life when these teeth are under development. So the first permanent molars and incisors are starting to develop at the last trimester prenatally, and the development is still around this age, and that's why this time is important in these putative risk factors.
And what about the genetic factors? Because we can read a lot of articles because the genetic background of this disease.
Yes, nowadays there are more and more studies that it has a genetic influence as well, but still this is a multifactorial etiology, so we still doesn't know that which influence more the development of the enamel.
Okay. Thank you very much.
Thank you very much. My congratulations with your progress. Maybe I didn't get, but can I ask you two related questions? So the first one is regarding your first project, is about your population. So do you exclude the other potential etiological factors for the hypomineralization, like, I don't know, celiac disease, as you mentioned in the second project, or some other pathologies of the gastrointestinal tract? And the second question is due to which disease, infection disease, this patient were on antibiotics?
Okay, so for the first question, yes, we included just the patients who were healthy, and we excluded all the population where they mentioned that they had any diseases. And can you repeat me?
Due to which diseases the patient got the antibiotics? What are they?
It's not listed in all the studies, but mainly these are respiratory diseases or other infectious diseases for the use, but unfortunately some of the studies listed it just where they have used, and that's why I mentioned in the limitations that this is the problem and the leakage, that it was not mentioned that this antibiotic was used for this disease.
Yeah, because if the patient would have some infection of the gastrointestinal tract, it will in the future can influence the absorption of the minerals and different, I don't know, vitamins as well, so it can affect actually the result somehow.
Yes.
Okay, thank you very much.
Well, I might have a short question, just a short one. About your second project, what wasn't very clear to me is you have the patient population, you have an exposure and an outcome clearly defined. But what I don't understand is what kind of study that's going to be. Is it going to be a prognostic study where you're looking at the correlation between the prognostic factor and the outcome? Or is it going to be a comparative study of what happens to those with the exposures and what happens to those without the exposures? So is it a PFO or a PECO, actually?
It's a PO. I mean, it's a prognostic. So we would compare these. If someone has this phosphocalcic metabolic disorder, have also developmental disease.
So you would compare? Do you compare someone to someone? Those without the disorder and those with the disorder? Or do you just see what are the chances of development?
Sorry, the chances.
Okay, so it is prognostic, and what are the chances
yes,
of?
yes.
So this is going to be correlation between the factor and the outcome.
Yes.
Perfect. Thank you.